This is Frontline host Ryan Stanton. Before we get into today's episode, I wanted to invite all of our listeners to join me in Chicago this October for the 2026 ACEP Scientific Assembly. Alone, we each take care of our patients, but together, we can change the face of emergency medicine. Join me and thousands of your colleagues for ACEP 26. Register now at acep.org/ACEP26 and get free access to ACEP anytime. We'll see you in Chicago. Ryan Stanton here with ACEP Frontline, and we're going back to Colorado, checking out the 4th Annual Leadership Symposium and EM High Risk Do Not Miss Conference. And this is one that is very important to almost everybody across healthcare and honestly everywhere else as well, and that's the current and future of artificial intelligence in emergency departments with Dr. Jesse Pines. He's one of the leading innovators and researchers in emergency medicine, and he wrapped up one of their days there with a conversation on this topic, and this one's very important for the American College of Emergency Physicians as well, in terms of where we're going, how it's appropriately implemented into our healthcare setting, but also how those that may challenge us are using it as well, such as the insurers that are using it for down codes and denials. We have seen some recent discussion on some of that, especially the law that was recently passed in Illinois that is also getting traction in other states as well. So here's a great opportunity to learn about where we are at the moment with the current and future of artificial intelligence in emergency departments with Dr. Jesse Pines.
All right, so I think I have the coolest job in emergency medicine because I am the chief of innovation for a large physician group, and I get to do really cool stuff like work on artificial intelligence and also become the ostensible expert in something I knew nothing about 2 years ago. So I have been working on artificial intelligence, and this talk is really about looking at what we are currently doing now in artificial intelligence, and also some of my opinions on where things could go in the future. And these are opinions after I spend probably about 70 to 80% of my time now sort of working on AI projects and thinking about AI. First, I'm gonna explain to you sort of what AI is. So we're gonna talk about how AI is different from other types of computing. We're gonna look at some of the clinical challenges of AI because that's honestly what we deal with on a day-to-day basis in terms of there's the technology, there's the implementation, there's the expectations, there's the, people are expecting AI to be able to do all these things, and then getting into the clinical environment is quite a process because there's people who are at very different levels and very different interests in terms of using AI. And then at a very high level, I'm going to go through some of the use cases of clinical AI. So not going to talk about AI for billing, but here are some of the ways that we can use it in a clinical environment for research and for quality improvement. And this is based on a paper I did with a former fellow of mine, Mika Kochman, who is now one of our medical directors in Maryland. Okay. So who here uses AI? Who here has used AI before? Okay, almost everyone. Who here uses AI on a daily basis? Okay, so about half of you. So this has been, something that has been, it's very rare for a technology to get out there where all the hands are going to go up roughly a year after something gets released. But AI is everywhere, as we know, from productivity tools, summarization of documents, for creative generation. There's Sora AI now. You can create these cool videos. Who here has used AI to plan a trip? So definitely recommend, if you're going to go on vacation, ask ChatGPT to help plan a trip for you. It's awesome. So AI is in everyone's pocket. It is in I've got two high schoolers. It's in their pocket. It is helping them more than I want in high school. But AI is everywhere, and there are all these new companies that have come out. AI is also in healthcare. This was a slide from about 6 weeks ago that sort of lists all of the various AI solutions in healthcare. And there's a new company pretty much every day coming out. And if you're on LinkedIn with a title like mine, you hear from all of them. Okay, and they want to say, I want to give you a demo. There are a number of different areas. There's lifestyle management. There's clinical AI in the hospital. There's wearables, virtual assistants, mental health chatbots, medical imaging and diagnostics, patient and data and risk analytics. So there's a ton of different types of clinical AI that we're seeing out there. So what's AI, right? So you open up ChatGPT, like what is this thing doing? And at the very sort of million-foot level, what it's trying to do is mimic human cognition by assessing patterns through natural language processing, taking speech to text or this unstructured data. It can recognize images, and then it's also into robotics, where AI can sort of sense the environment and then choose actions based on the environment. So how does AI arrive at an output? So you put in your prompt in there, and then AI arrives at an output based on ostensibly looking at a big training data set, looking at patterns in that data set, and then trying to predict what is really the next word or thing out there. So it's basically a probabilistic prediction model it's not rules based. So it's not like, the HEART score is like a rules based algorithm. Plug in here and you end up with X. So AI is sort of a probabilistic way that brings in large amounts of information based on training data, and then comes up with whatever it thinks the most likely answer is. So again, it's sort of a prediction tool that can take enormous amounts of information and then summarize that. And the human brain sort of works in the same way. The human brain is ultimately a prediction tool, and you have different types of AI. You've got AI that can summarize, AI that can generate. Arguably, all AI is sort of generative. It uses a large language model. And again, you've got this concept of what's called training data. So ChatGPT 5 is the training data is the entire internet. Who here uses open evidence? So lots of hands. So open evidence does not use all of that as training data. Open evidence uses JAMA, New England Journal, and PubMed, and then all the free stuff related to PubMed. So that's the training data from which the large language model will take your input and come up with a prediction. And it's cool because you've got these, it's so easy. You open it up and you put in your question. What we've found out more and more is how you ask that question is actually very important. And there's different ways of, in particular, asking medical questions that you can get a better answer. So for medical questions, it's based on where you ask that question. Is this a medical specific open evidence type large language model? Is this ChatGPT? But also how you structure that and the data that goes into that very much will determine what the ultimate answer is. So what are the challenges? So who here has used AI clinically in the emergency department? Okay. And a lot of that may be DAX for ambient, that may be using ChatGPT, that may be asking open evidence questions, that may be a lot of different things. I think in 2 years, it's very likely that 100% of the hands are going to go up, that everyone is going to be using this in some way or another, or this will be in the backgrounds. But so what's the issue here is that it's based on training data, right? It's based on training data that has assumptions, and training data may have assumptions that can create bias. So if you have biases in your training data, you're going to have biases in your output, racial bias, gender bias, SES bias. Another big issue is regulation, right? So, how do you regulate this thing that changes so frequently, right? So the, ChatGPT 3.5 hallucinated a lot more than ChatGPT 5. So do you get ChatGPT approved is this a software as a medical device? It sort of is, right? Because it's giving you answers. And, we've seen approvals for various types of ambient AIs from 18 months ago. The hospital says, yeah, you can use it. And 18 months later, it's a totally different product. It does totally different things. The security features are totally different. How it stores information are totally different. So this is a really big issue. Malpractice. What if AI tells you the wrong thing to do and you do it? Who is at fault? Is it the AI? No, it is you as the physician. And at some point, I would guess to say that not using AI because it will be so helpful to us could be malpractice, because the AI is going to be in the background analyzing data as an assistant, and not using it if in the case where AI would have found something could be malpractice, because what's going to happen is something bad is going to happen. The malpractice lawyer is going to take the entire chart, ingest the chart, and have whatever AI spit out what the AI would have done, right? So if you're not using AI in 5 years from now, I think people are going to be at a real disadvantage. Data security, also a huge issue. Who knows how long DAX actually keeps the patient voice? It's 90 days. They keep a recording of the patient voice for 90 days. We are trying to push them back. The new version of DAX Dragon is going to be 30 days. But where is this information, right? Concerns over the workforce. Is AI going to replace emergency physicians? I don't think so. I think it's going to be incredibly helpful to us. Will it replace radiologists one day, or replace a lot of the functions of radiologists or diagnostic pathologists, or looking at skin rashes? I think that there's a lot that AI is going to do there. I don't think AI is going to replace us, but it's going to change the way we work. There's also, issues with sort of loss of personalization. Is AI less empathic? Issues of, can it really truly ask, and can it really answer complex clinical questions? Because there are all the factors that go into there that you would make a decision about really in there. Currently, ambient AIs use the patient voice, that voice to text. It does not use the intonation of that, right? So someone can say, yeah, I've got 10 out of 10 abdominal pain, with the Cheeto fingers, right? And laughing, versus someone who's screaming and yelling, I've got 10 out of 10 abdominal pain. It's going to go in the same, and it's going to interpret the exact same way. That's going to change at some point, where intonation will be taken care of, will be taken into account. There's also sort of the black box problem of like AI spits out an answer and like, how did it get there? And if you explicitly ask AI to verify the logic around what it's trying to tell you, it will give you, it's called the chain of thought. It will actually give you a breakdown of how it's thinking. And then hallucinations. This is a really, really big deal. Who here has seen AI make up a citation? Yeah, so it just makes it up. But if you tell ChatGPT to not hallucinate, it really lowers the likelihood. It's fascinating. You say you just say, "Don't hallucinate, don't hallucinate." It it it's just how the system works. Yeah. Yes. Okay. So we're going to go through some case studies. So people Google their symptoms before they come to the emergency department. Everyone's seen that. Interactive chatbots like ChatGPT or other AIs are going to have give patients a much better sense of what's going on. So it's going to be, I think, a much more helpful guide for patients in terms of what to do and where to go, but it is exquisitely sensitive to the input, right? So if the patient describes things a certain way, then that will very much determine the output. It also may not explicitly address atypical symptoms. In general, when you look at sort of medical recommendations, from these chatbots, some are actually showing they're actually better than physicians. But again, it's like physicians putting in this information and putting in everything and all the context, and it will come up with the right answer, but it's very dependent on the input. And I think will, at least for the near term, require verification. There are some studies showing that unsupervised chatbots don't have great performance. Who here has seen ESI, various triage tools with AI? Any of those? So I have seen a number of different pitches on this. They're implemented in some of our California hospitals. They're actually pretty good and better than nurses at assigning the proper ESI score. It's been very difficult to actually sell into hospitals because I think hospitals don't see this is a big hair and fire issue. It's expensive. But there are other tools out there that predict waiting times, other tools out there that I've seen pitches. I haven't seen this really get out there. I think that this will eventually, Epic's next generation, I think, is going to do some of this. Predictions of waiting times, notifications to patients. Perhaps you can build something in like, a cancer patient comes in with neutropenic fever. If that happens, page Dr. So-and-so immediately or send a text message. This is an area where AI is going to be super helpful, is summarizing the chart summaries. Who here has seen AI do chart summaries before? So it can do chart summaries pretty well. We're starting a pilot with a company called Abstractive Health. There are a number of companies in this area. We're starting with our hospitalists, where they're going to be able to get a sort of a full patient summary at the point of hospital admission, sign out to another hospitalist, and then we'll actually draft a full discharge summary for the hospitalist. This is an area where once this is in place and once this is out there, this is going to be incredibly helpful. What this particular tool, and again, we haven't implemented it, so I don't know how well this works in practice. There is a study out of Cornell where they did test the EM version of Abstractive Health, which does create a ED to hospitalist or summary, and it basically hooks into a health information exchange called Care Quality, or you can plug it in directly into your EHR. I've seen examples of this. There is a paper on this to show that it actually works fairly well. But this is going to be a use case that I think we're all going to very much want and use. EHR documentation. So who here is using an ambient so far? Okay, about half of you. So we have 6 different ambients we are working with across all of our sites. The way that ambient works is you walk into the patient room with your cell phone, you got Haiku from Epic, you're logged in through an app to an ambient AI, you record the patient conversation, you walk out of the room, you can call out clinical information beforehand, call out clinical information afterwards, and it will create a draft note for you. It's pretty cool. So DAX is the most common one that's being used inpatient, that's being used by our health systems as a client. We are using Clio Health. To answer the question about the RVU per encounter lift, we are looking at that now. Early results show that Clio is about 4%. This is in small in small studies showing again that because the draft note is more complete in terms of things that Dr. Adler talked about in terms of the COPA and all the risk stuff, it does actually increase the level of billing. We're doing an analysis right now where we're looking across all the six to see whether or not this is robust. This is a very, very preliminary finding, but so far the data we've seen is there an RVU per encounter lift when you implement this stuff? And the answer is yes, and it's not insignificant. So, but again, we will probably not publish this because I told our compliance people we're looking at this and they said, Jesse, you're not going to publish this, right? Because we're going to get into big trouble if we implemented a computer program and the insurance industry sees that we implemented a computer program and now our billing is higher. Ambient AI is going okay. Some people love it, some people don't love it. Some people love certain programs, and some people really don't like certain programs. And actually, DAX has an NPS of 0. Some people love it, some people don't love it. It's complicated to use. It's not specifically for emergency medicine. Clio has an NPS that is significantly higher than that, has a better adoption rate. So again, there's a lot of variation in terms of how these are. Also, these programs are changing very dramatically over short periods of time. So Clio, for example, has a patient experience module where it will give the clinician real-time feedback on certain elements of patient experience. And people actually accept this. Did you introduce yourself to the patient? Did you manage up your team? Did you talk about expected length of stay? It will give you a red, green, yellow when you walk out of the room. And it does change people's behavior because, if people have this turned on, it does actually change how people talk to patients. So co-piloting. This is another area that's going to be super, super helpful. But we've got to be very careful with this. So open evidence is very good because it, in general, does not have zero hallucinations, but it has many fewer hallucinations than ChatGPT. But you have this thing called AI-generated MDM. We're actually looking at this now where you have what you put into the chart, and then it will output other things that you may not have thought of. It will output a differential diagnosis that may be a little wider than what you dictated. We are currently looking at this now because this is an area where AI could be potentially very helpful if it pings you and said, well, you didn't think about this, and somebody up front, it's a fever. Somebody up front said that it's a fever and the patient just returned from Kenya. Did you think about something? And you're like, oh, I didn't see that. I didn't see that. Now I'm going to change my differential diagnosis because the AI is sort of looking at everything. So this is not imperfect data. So before we started a pilot with Clio, a number of our docs had AI MDM clicked on, and essentially it will spit out a pretty good note for you, like at the beginning. And it's super helpful. It'll do a full note for you, saves a lot of time. And, from over about 6 months, having that clicked on, the folks locally are saying it's right about 90% of the time. So 10% of the time, it's wrong because either you didn't put in enough information or, it just got the answer wrong. So this is an area of active study. We currently have AI generate MDM clicked off. Who here has seen PM Cardio, Queen of Hearts? Okay. Who here is using it in clinical practice? So it is not approved for use in the United States. So please be careful with this. Yes. But it will be approved, I think, Q1 of next year. And basically what this does is little squiggly lines of EKGs. We should not be independently reading these things in 5 years. We should have an AI helping us recognizing the subtle stuff, and that's what this does. Basically, there's a new category of occlusive MI, that something that's about to become a STEMI that does pretty well predict the arterial occlusion. This is stuff that we're going to see. I've pushed back on their business model. So their business model, they want to charge. This is as of at least 6 months ago, $30 per clinician per month to use this thing. I'm like, well, why don't you just embed it in the machine that does the EKG and put it up, So, we'll see where that goes. But I can see this being very helpful once we get that implemented. Handoffs, I haven't seen. The only one I've seen is abstractive health, but it can totally create a summary for a handoff. Pending items. So abstractive health does not do a summary at ED sign out, but AI could very easily do this. And I would say that someone's going to implement this at some point. Interpretation of test results. Who here has uploaded labs to ChatGPT in a blinded way? Super helpful. It's super helpful. Putting the labs and the clinical data. You have, Leon? Maybe. One person admits it. But it's super helpful, right? Because it will come up with things that maybe you didn't think of, and all the different alkalosis, acidosis. You put in abnormal labs in a critically ill patient, and the insights are actually helpful. Generating reports of radiographic images, radiologists are already doing this now, where there'll be the AI read, they'll go through it, they'll check. Incorporating results and now your differential. Haven't really seen that unless you're actually sort of iteratively doing that. One of the things we're trying to do next year is actually sort of plug some of these AIs together. So to have your Clio on and you've got your open evidence in your Clio, and it's all working together. Open evidence does have its own ambient that doesn't work as well, but that's another way to do it. Risk scores. This is actually one area that we're just looking at now. Is in general, most of the tools for best practice alerts or whatever you call them are not helpful in electronic health records. We are starting to test AI gently nudging a few things and saying, if you see this combination of things, just nudge about the heart score, about documenting a NIH stroke scale on a dizzy patient. Really, I think to be determined whether or not this stuff will actually help, and whether or not the clinicians are going to want to sort of actively prompt and versus being poked. Another area, who here has used AI for discharge instructions? Yeah, so it's actually pretty helpful. Personalized discharge instructions, screening for appropriateness. med safety, being the AI in the background, making sure that the right medications are ordered, assessing patient cost. This is something that we don't necessarily do, but that could be something that's built in. Creating a request for an automated follow-up appointment. Maybe that's something AI could do. One of the new projects that we're launching is with a company called Rely Health, which has an AI chatbot at ED discharge. Pretty cool. So, again, we're still in the early phases of formulating this, but the idea is high-risk patients would get a push where an AI chatbot would look in the electronic health record and actually could have a conversation with them at discharge or after discharge, and it will ping them 3 times. They told us that they're getting a engagement rate of about 60%, which I don't know if I believe. We do something similar with text messages and with emails, where we'll email the patient and text them after they're discharged from the ED. How you doing? Are you okay? Could you get your prescriptions filled? We get about a 10% engagement rate for that. But the AI chatbot, I've seen it work in practice. It's actually pretty cool. It can have a full conversation with the patient, and then we'll sort of flag issues and get the issues to whoever the right person is. Set up a follow-up visit. I can't get my medications filled. Again, does this work in practice? The answer is I have no idea. It looks pretty cool, and we're going to try it. Again, this is really the use case. Contacting the patient after discharge, assessing the need for a callback, some sort of check-in, and we're actually we're going to be linking this together with a telefollow-up program. So if someone gets to the point where they need a telefollow-up visit, then we could potentially schedule that and get that person assessed in relative real time. Number 10 is for quality improvement and research. So this is, I think, a huge area that's going to be, I think, one of the near-term use cases. So, as someone who's done a lot of research papers, a lot of what we use for research is the structured data, right? We use structured data to look at the association between X and Y because we know definitively the patient's age, we know whether they died, we know which emergency department they went to. These are sort of structured data elements, but what we don't use in research often is the HPI and the ED course and all of this unstructured data. This is going to be a gold mine for research. Another area this is going to be a big gold mine is for chart reviews, because we have regional quality directors, local quality directors, folks all over who are reading through charts and making assessments. We are just starting to test a new process where AI is going to do some of this. Where can AI give insights about the chart and then give that insight back to the clinician? So for example, when it comes to documentation, we see a lot of variation in the site in terms of how people are documenting. AI could ingest all of those charts and actually give specific examples of where the documentation was lacking and then what documentation would have looked like. I mean, the ability to do feedback with AI, I think, is going to be huge. Again, we're sort of, does this stuff work? We're in the very beginning. I've got no idea, but it has incredible potential to give feedback because, a lot of our programs where we give feedback for quality. So, for example, we have a program called our Provide program, where we give feedback around admission rates for high variation conditions. And, we see a lot of variation, chest pain admissions. Some people admit more, some people admit less. And when we give feedback to the clinician, they say, okay, so, I'm admitting two times what other physicians are in my department, show me the patients that I could have discharged. And we say, well, here's the list, and you got to look at them, and someone's got to look at them, and what does this variation mean? AI is going to be able to really give true insights for quality improvement. May be able to do this. But incredible potential for assessing quality of care, for, I think, creating potentially new quality measures for healthcare. This is actually number 10. This is one of the ones I'm probably most excited about in terms of near-term possibilities. So last slide here. So where is this going in 5 to 10 years? The answer is, I don't really know. But where could it go? I see it being very integrated into ED care at a lot of these different levels in 5 to 10 years. I think that we will still need emergency physicians. I don't think that this is going to dramatically change the distribution of our workforce. It's going to make our jobs easier in a lot of ways. There will be, I think, more scrutiny. There's been a lot of discussion, whenever there's sort of a revolution like the Industrial Revolution, everyone said all the jobs are going to go away, everyone's going to become unemployed, but it basically breeded a whole new, different types of jobs to fix the machines. I think AI is going to do the same thing. In terms of whether or not will it really dramatically alter the workforce in emergency care, in healthcare in general. I know that my niece just graduated from Bryn Mawr College with a political science degree with honors, and she can't get a job, right? So the AI will impact certain professions. I think that emergency medicine will be less impacted than others. I think that there's going to be a ton of issues on implementation. Especially the human issues of getting people to use this stuff, making it work well. We know that different ambience. Some are very difficult to use. Some you press one button and it works. It works out of the box. We've got to design it, implement it in a thoughtful way. We've made, in the last year, I've made a ton of mistakes. So the mistake of ambient when you're rolling it out is to send out a bunch of videos, send people their accounts, and they say, go ahead and try it. That does not work. Do not do it that way. You need champions. You need someone who really knows how to do it, who can convince people and show them that it works, and then build it out from there. And it's a 3-month process, and you'll get much better adoption that way. There's going to be a ton of issues, data safety, liability. There will be data breaches. There's going to be evolving regulation. We have an AI governance committee in our company, and it was actually started by the compliance people and the lawyers who are all very concerned that the AI laws in the various states are all very different. The consent laws around recording and how do we talk to our patients. This is going to be an incredible evolving area.
We open up for questions here, and the first question is about assigning learning objectives to programs such as Clio based on the patients you've seen and learning objectives. So here is the answer to that from Dr. Pines.
That is coming in Clio. Savant has that. I haven't actually seen that. Haven't seen that work. I know that they do that at some of their academic sites. I haven't seen any data on that, but it's very possible. And the concept would be to look at all the patients you saw, give you sort of a post-shift report. For residents, it could actually come up with 10 multiple choice questions. There's, so I would say soon.
In our second question, we hear about some of the funding and the differences in groups with the implementation of AI within ambient listening and other technologies.
Yes, so if we bring the AI, we are funding it. If the health system is the client, they are funding it. Although there are some examples where they are starting to say, well, you are an employee group, or you are a vendor. Why don't you pay the $250 a month for whatever it is. I'm not exactly sure where that's going to go, because I think the sort of the big existential question of ROI for hospitals and health systems in the outpatient world, I think it's been proven, but in the hospital, it's still an open question. And if they are not seeing the ROI, then they may choose to decide to either charge groups for using it. At some point, I don't think they're going to necessarily turn it off. Epic's product is going to be, I think, one price for all of their AI stuff. So you're not going to be able to like opt out. And Epic has like tons of AI things in the works that they're going to be implementing. And it's going to be an all or none kind of thing.
In the following question, talking about some of the responsibility for the content of the note, especially when using ambient listening or AI-based assistance tools, and who is responsible for the final product. I bet you can guess the answer here.
Yeah, we really haven't seen that. And the way that we message it is you as the clinician are responsible for your note. You have this tool, it's like if you have a human scribe, if the human scribe gets it wrong, it's still your responsibility to go in and fix whatever they wrote. It's the same thing with ambient AI. But the human scribe can make errors that would be substantial that could be put in the chart in the same way. So it requires human verification. We did have a couple instances where AI generation was turned on and people were not reading their notes, and it did create some problems. So, everyone has to read. You got to read it, and so absolutely. Yep.
In this question, they ask about the use of AI and whether it could potentially hinder new resident education and potentially create a blind spot within our ability as physicians to translate our medical knowledge into the bedside practice of emergency medicine.
So that is a great question. And, I think when most of us, all of us in this room trained, what is the hard part of intern year is that blank space of your medical decision making and thinking through that and writing it down and getting feedback and iterating on that. AI, it does allow you to go, do that for you. Is that going to make us worse doctors one day? I mean, I would use the analogy of my 17-year-old son in his English class when, kids in high school are using this to generate essays and what have you. People are using it to generate articles for it's a tool out there in the world, and I think it's going to be difficult to regulate. I think we should create guidelines around education, and I think that the chance that a resident is going to miss something in terms of something AI generated could be higher than someone who's an attending physician. So I think it's going to require a lot of scrutiny. I think SAM is looking at this now. I've heard there have been discussions there, but I haven't seen any guidelines.
This question is about whether there are any currently existing autonomous services being provided via AI with regard to patient advising, education, or prescribing/treatment.
Yeah, I haven't seen any examples of autonomous chatbots giving recommendations on behalf of the health system. So I don't see that happening anytime soon, just because of the liability of that. Because you don't know whether if it gets it right 90% of the time, then it's getting it wrong 10% of the time, and also you don't know how patients are asking questions. So I don't see this happening autonomously. Where I do see it helping on I think it will help us more than insurance companies for a lot of this billing stuff, because on a number of different levels, one, it will help us document a better chart. Insurance companies will I'm sure come figure out a way to fight back about and downcode in other ways. But the amount of energy that it takes for us to maximize documentation versus what insurance companies to minimize payment. That's all they do, and we do this and a bunch of other stuff, right? So I think it's going to unburden some of that workload.
This question is about the AI's ability to translate and provide a note in our native language based on the information provided by somebody speaking another language, and the responsibility for that accuracy secondary to it translating a language which the interrogator does not understand.
So you are responsible for your note. You are responsible for your note. That's
okay.
So and I think a good example is, so Tesla has their self-driving feature.
Yes.
So which they initially called it self-driving, and now it's called fully supervised driving because a Tesla unfortunately ran over a couple that was walking across the street, and $327 million later against Tesla because they said it was self-driving. Now it's it will always default back to the clinician. Can AI do language translation? Yes, absolutely. I haven't used it for that purpose, but and some of these ambients can do Spanish and other languages.
As we wrap up the session, Dr. Pines talks about two areas where we can read up on the future and direction of AI. So some AI-based expertise, if you like to get out that old printed paper or online, wherever it is, and check out some of the direction from the experts of where AI is going and what to expect in the future.
The two people to read in terms of opining on this are Yuval Harari and Ray Kurzweil. Okay, in terms of where are things going, and so Yuval Harari said he's much smarter than I am. What he says, he wrote *Sapiens* and a number of other books. He thinks that AI is going to slowly take things over, and people are going to have to retrain multiple times in their career, where where our kids 20, 30 years from now are going to have to, maybe they were trained in X, they're going to have to move to Y because X has now been automated, right, with AI. So Ray Kurzweil sort of sees it a little bit different. I mean, he sort of goes back to this Industrial Revolution thing, is that he thinks a lot of the productivity gains are going to be really outsized, and it's going to create a whole bunch of new jobs and new roles. And you can think about a graphic designer who today is drawing the pictures, and maybe the graphic designer of the future is teaching AI to do this in a way that but still you have a job in graphic design. You're just sort of doing it differently. And the way I think about it with my kids is it's a tool in the world, right?
Dr. Pines opines about what he feels is the future jobs that may not be the right direction to go, and with that conversation of when will AI replace most of the jobs across this country and around the world.
I would say don't become a truck driver, one.
Yeah.
Because trucks will be, 10 years will probably be driven by big Tesla trucks. I think a lot of that's going to go away. I think, through the Industrial Revolution, a lot of the manufacturing jobs went away. But I think the workforce will change. And yes, and I am preventing the group from your alcohol, so I don't want to do that any longer.
Dr. Jesse Pines with the current and future of artificial intelligence in emergency departments from the 4th Annual Leadership Symposium and EM High Risk Do Not Miss Conference from the Colorado chapter of the American College of Emergency Physicians. Welcome you. I will actually be at the upcoming conference in November of 2026, and I hope you'll join us there for that. A great setting at Beaver Creek in Colorado. Probably won't have a ton of snow at that point, but still an incredible place to have a conference, and beautiful to say the least. So check it out there, and I invite you to join us there, and also invite you to join us at ACEP 26 in Chicago, Illinois. Looking forward to being there for a wonderful week in Chicago, and I know that state is going to be very welcoming and put on a fantastic show, and we look forward to the adventures that we'll have. If Feel free to contact me, rstan@acep.org, rstan@acep.org, at EverydayMed on X. Also, check us out on Facebook and Instagram. I ask you to please subscribe to the podcast on your favorite player. Encourage your friends and neighbors and healthcare professionals to do so as well. Give us a 5-star rating. Give us a 5-star review. We love that, and it'll help boost us up. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.